In this video, we'll discuss how to approach to make a diagnosis of headache. In the OPD, many patients come with headache and they come with the complaints ki doctor, I have a headache, so will I go for a CT scan because I think there is a tumor in the brain. So that is one of the common problem that we physician face in our OPDs. So this video we will see how to systematically approach headache diagnosis, when to order the investigations, when to make a clinical diagnosis, when to refer the patient. Causes of the headache. Causes of the headache can be divided into two groups. First group is primary headaches where there is no identifiable underlying cause. These are migraine, tension headache, cluster headache. Other group of headaches are secondary headache. Secondary headache means there is some underlying cause which has led to the headaches, like systemic infections, any head injury, vascular disorders, intracranial hemorrhages, brain tumor, sinus venous thrombosis. So these are the causes of secondary headaches. Coming to the secondary headache, with the help of some important keywords or key symptoms or manifestations, let's see how can we make the diagnosis of these secondary headaches. Meningitis. Meningitis is one of the medical emergency. Patient has to be referred to the emergency. Patient will tell you that there is a acute severe headache, there is neck stiffness, fever, and this headache increase with the eye movements. Intracranial hemorrhage, acute headache, maximum in 5 minutes. Subarachnoid hemorrhage, patient will describe subarachnoid hemorrhage as the worst headache of the life, lasting for more than 5 minutes. There will be neck stiffness but without any fever. This feature differentiate clinically it from the meningitis. Brain tumor. Brain tumor are moderate intensity headaches. They are intermittent, deep, and dull aching pain. They become worse with exertion or change in the position. Nausea and vomiting will be present. Vomiting that precedes the headache by weeks. This is most likely a posterior fossa brain tumors, while head pain appearing after bending, lifting some objects, coughing. This is due to posterior fossa brain tumors or other malformations or low CSF volume. Temporal arteritis. Vasculitis, this is one of the important vasculitis. This is seen after the age of 50 years. This will be worse on lying down. So patient will tell ki whenever he or she lies down, headache aggravate. It is also aggravated by exposure to the cold, and there will be associated condition polymyalgia rheumatica. Jaw claudication will be there while eating the food. Patient will complain of jaw claudication, jaw pain. Glaucoma. This is related to severe eye pain. Red eyes will be there. Dilated pupils will be there. Cerebral venous thrombus. Cerebral venous thrombus is characterized by this sequence of headache, seizure, and stroke. Papilledema will be there, and stroke will present as bilateral neurological deficit, and that will be in a non-arterial distribution, means it will be a diffuse type of neurological deficit. Coming to the primary headache disorders, three important: migraine, tension headache, and cluster headache. Let's see how to make a diagnosis of migraine. Migraine is purely a clinical diagnosis. It is repeated. 4 to 72 hours is the duration. Normal physical examination, no other cause. It will be associated with more than two of the following feature. It is unilateral, it is thrombing in nature, like pulsatile vessel, increased by movements, and it is moderate in severe intensity. Patient will lie down to get the relief from the migraine attacks. Plus, any one of the following, like nausea, vomiting, photophobia, like it will aggravate on light exposure, or phonophobia means sound exposure, patient will have triggered headache. Tension type headache. Tension type headache is bilateral. Patient will say that there is a constriction band around both sides. It is without any other features like no nausea, vomiting, photophobia, phonophobia, There is no throbbing headache. It is not aggravated with movements. So it is without any these characteristic feature which were present in the migraine attacks. Cluster headache. Cluster headache is very severe headache. It is retroorbital, typically stabbing in nature. Periodicity will be there, that it comes on the same time of the day. Autonomic activation will be there, like patient has lacrimation, rhinorrhea will be there, nasal congestion will be there. Now coming to the most important aspect of the headache, red flag signs, because not all the headache will be treated in emergency. Most of the headache which comes to the OPD, they are benign disorders, but we should be very careful about referring the patient. We look for those red flag signs always. Patient describe, doc, this is my worst headache of life. Always suspect subarachnoid hemorrhage. Sudden and maximum at the onset, intracranial hemorrhage. Pain that present immediately or upon awakening in the morning time is due to raised ICT. Vomiting preceding the headache by weeks. Pain induced by bending, lifting, coughing, or abnormal neurological examination. Some sort of mass lesion is causing these features. Neck stiffness, fever, decreased consciousness, altered sensorium. Always suspect meningitis. Age more than 50 years, temporal artery tenderness is there, temporal arteritis. New onset in pregnancy or postpartum period, this is suggestive of cortical vein thrombosis. Papilledema is there, suspect mass lesions, meningitis, or pseudotumor. Known systemic illness like history of cancer or HIV, always suspect that there is some sort of metastasis or opportunistic infection in the brain like toxoplasmosis. Coming to the approach to the headache. Whenever patient comes to us, we will identify what are the emergency causes of the headache and what are urgent causes of the headache. Emergency causes means you have to refer the patient immediately to emergency for workup and management. These are intracranial hemorrhage, subarachnoid hemorrhage, venous sinus thrombosis, meningitis. Urgent: temporal arteritis, mass lesions, pseudotumor cerebri. Urgent means ki you refer the patient to a specialist. If the patient is coming in the morning, then tell ki you can visit the specialist after that. Means ki there is no urgent rush. Maybe if there is a holiday, then the next day patient can visit the specialist. If patient has history of worst thunderclap headache, worst headache of the life, subarachnoid hemorrhage, fever and neck rigidity, meningitis, papilledema, seizures, non-arterial stroke, venous sinus thrombosis. If these features are present, this is emergency. Refer the patient to emergency for brain imaging and lumbar puncture. Brain imaging means CT scan or MRI and CSF fluid analysis. Patient does not have these features. Then ask for jaw claudication. Tender temporal artery sign should be assessed. Age more than 50. Temporal arteritis. Papilledema, morning headaches, some mass lesion is there. Eye pain, redness, glaucoma is present. Papilledema, and there is history of some drug intake, so it could be pseudotumor cerebri. If these features are present, refer the patient to the specialist. If these features are not present, most likely it will be a primary headache. Primary headache means migraine, tension headache, and cluster headache. This patient will be treated in OPD. So this is how the management of headache or the approach to the headache will be done. In the subsequent video, we will discuss the management of migraine headache. Stay tuned, and if you have any questions, any doubts, you can put in the comment section. Thank you.